Good afternoon, everyone, and welcome. I'm Alan Scheller-Wolf, Professor of Operations Management from the Tepper School and one of the three co-chairs of this INTERSECT conference. Thank you all for being part of our third annual INTERSECT at CMU. Before we begin the program, it would be remiss if we didn't take a moment to remember the events of 19 years ago, September 11th, 2001. As we talk about the current crisis facing our country, we should take a moment to reflect on that past one. And I invite you all to join me in a moment of silence for the victims. Thank you. Now on to today. I'd first like to thank everyone who helped organize and support this conference, the members of the organizing and planning committees, the deans, the students. Please be sure to check out StudentSect as it completes this weekend, as well as the Central University for their support, particularly university leadership, marketing and communications, university events and advancement. Everybody, you know who you are, who's helped out, and you've done a fantastic job. I'm so grateful and proud of all of you. I also want to send a special thank you to our speakers and participants, our sponsors, and all of our guests in the audience. When I heard the final registration numbers, I was frankly blown away. Welcome, everyone. This is our third year holding INTERSECT. We started with the Tepper Quad opening with a conference that highlights business, technology, and society. Last year, we focused on healthcare. This year, we initially thought we would talk about sustainability. But like everything else over the past 6 months, events changed our plans. Given the potential dramatic and long-term effects of the COVID pandemic, we chose to refocus our conference on COVID, incorporating sustainability as a subtopic, along with health, the economy, and education. We also chose to specifically incorporate technology perspectives around technology, humanity, and equity to explore how COVID is affecting society more broadly. Of course, COVID is first and foremost a medical phenomenon, so it makes sense that our first topic, today's topic, is organized around health. This afternoon, we're going to explore how our current healthcare system is coping with the pandemic and how we can try to build a system which is more robust to public health emergencies like this in the future. Basically, how can we get through this and how can we do better going forward? This frankly matches our vision of INTERSECT, which I argue is both simple and profound. To solve the big problems in society, we're going to need to work together across campus, across Pittsburgh, across the globe. Different colleges, disciplines, perspectives, different ideologies. We need faculty, researchers, students, policymakers, activists, practitioners. We're going to have to all come together, talk, listen, and work together. This is what will give us our very best chance of solving society's most pressing issues. In a word, we're going to have to intersect. That's a really big ask. Fortunately, we have a truly outstanding program prepared for you today to help start these discussions. To kick it off, it is my great pleasure to introduce the president of Carnegie Mellon University, President Farnam Jahanian. He's a nationally recognized computer scientist, entrepreneur, and higher education leader. Dr. Jahanian has already had a huge impact at CMU, and we're delighted he's able to share his welcome remarks with us today. President Jahanian.
Good afternoon. On behalf of Carnegie Mellon University leadership, welcome to the third annual INTERSECT at CMU conference. I wish to begin by thanking Alan for serving as a co-chair of the conference committee, along with Philip Lehman from our School of Computer Science and Jackie Speedy from the Heinz College. I'm grateful to all of our organizers, speakers, and panelists who have helped develop an extraordinary program. Our programming actually began last night with a conversation between trustee Glenn DeVries, a CMU alumnus and co-founder of Metadata, and Rebecca Dorge, our Dean of the Mellon College of Science. I want to thank Glenn and Rebecca for bringing us such an engaging discussion on the data revolution in healthcare. There's also some wonderful student-run programming taking place during this first week of the conference. Launched this year, INTERSECT at CMU is designed to enhance our dialogue with important and timely student perspectives. Thanks again to the CMU students who organized this. I want to encourage all of you to check it out. Finally, I also wish to thank our corporate and foundation sponsors for helping to make this event possible. We are so grateful for your support. As Alan mentioned, we're now in the third year of the INTERSECT at CMU conference, and this year's program is unique in so many ways. Normally, we would all be gathered in person in the beautiful Tepper Quad for this event. But like so many engagements this year, we're coming together in a whole new way. This is just one example of the way that COVID-19 has changed our lives, seemingly overnight. But of course, its impact goes far beyond events and gatherings. As everyone is keenly aware, this pandemic has caused an unprecedented societal shift, the likes of which we have not seen in our lifetimes. Our society has been dealing with so many challenging issues these past few months. Of course, many of which existed before COVID-19, but have been accentuated by this public health crisis. There's so many questions to explore together. So we decided to dedicate this year's conference to considering the pandemic's long-term global effect on four foundational elements of society: health, sustainability, the economy, and education. We will tackle one theme each week, starting today with a session on health, featuring a keynote by Professor Evelynn Hammonds of Harvard University. Thank you, Professor Hammonds, for sharing your insights with our community today. There is no doubt that we face many challenges ahead, but we must also embrace opportunities for innovative solutions. We must be willing to disrupt and break down disciplinary silos and bring together bright minds to solve complex problems. This is the inspiration behind INTERSECT at CMU. I hope our panels, discussions, and keynotes today and throughout the series will inspire and challenge you at this pivotal time for humanity. Once again, welcome to INTERSECT at CMU conference. I look forward to engaging and impactful conversations in the weeks ahead. I will now turn the program back over to Alan to introduce today's keynote speaker. Alan?
It's now my great pleasure to introduce Dr. Evelynn Hammonds. Dr. Hammonds is the chair of the Department of the History of Science and the Barbara Gutmann Rosenkrantz Professor of the History of Science and a professor of African and African American Studies at Harvard University. She earned a BS in physics from Spelman College and a BEE in electrical engineering from Georgia Tech, then an SM in physics from MIT, and finally a Ph.D. from Harvard from the Department of History of Sciences. Professor Hammond's current work focuses on the intersection of scientific, medical, and sociopolitical concepts of race in the United States. Dr. Hammonds thus is uniquely positioned to share with us perspectives on how the issues of science, medicine, and race can provide insights in COVID, and how COVID can help us better understand issues of science, medicine, and race in our society today. It's indeed an honor and a privilege for me to welcome Dr. Hammonds to be with us here today. Dr. Hammonds?
Thank you, Alan, and thank you, President Jahanian. I'm very happy to be here with you all today. The program looks wonderful, and I'm sure you're going to have some engaging conversations. I just want to make a few remarks about the work that I've been doing since late winter and early spring about the COVID epidemic. And let me begin, if I may have the next slide, with an introduction. And a lot of my slides have lots of text on them, but I hope that I can point out the salient points that I'd like you to take home. The first thing, and probably the most important one, is pandemics don't produce inequalities, they reveal them. And the two crises that we have that have defined the summer of 2020, the escalating police violence, worsening public health situation, both of these have disproportionately targeted communities of color. And while the killing or maiming of people of color by state authorities has been quite visible, the extraneous failures in healthcare and public health have actually been much more numerous. And the privatization of healthcare and the failure of policy decisions by the US government have actually led to, have helped us to see the persistent disparities in health. And the coronavirus pandemic has certainly exacerbated these problems. So let's just turn to next slide. And I hope you can see it. You will not be able to see all the numbers, of course, but if you just, this is a picture to step back and look at what the continental United States looks like in the face of this pandemic. Okay? You can see there's very, very few places that are lightly colored, and basically those are the places where the presence of the virus are the smallest. But as you can see, for the rest of the country, we are facing an enormous, enormous problem that is still quite complicated. Next slide, please. And so what I want to point out today is only by understanding and confronting the entangled web of racism and public health can we actually solve a problem that has been centuries in the making. Next slide. So I want to explain these, what I call predictable explanations. As information about the spread of COVID increased on various media platforms and cable news by early April, I waited anxiously for the proverbial shoe to drop. And the shoe being a metaphor for the news that poor people in urban areas, specifically Black and brown people, native born and immigrants, were disproportionately affected by the pandemic. And the news was followed by a rash of stories that made the point that African Americans in the so-called hotspots, cities such as New York, New Orleans, Detroit, Atlanta, Chicago, those with high concentrations of African Americans and Latinas, but I will be speaking primarily about African Americans, we were seeing the highest numbers of cases and the highest numbers of deaths. And so the predictable explanations began, and that's why I took this label. The disproportionate impact of COVID on African Americans was due to, as some people said, one, high rates of existing chronic diseases, such as diabetes, hypertension, asthma, and obesity. Two, greater likelihood of being uninsured and thus less access to health care. Three, more exposure to the virus due to holding more low-wage jobs in food services, public transit, hospitals, and other public-facing jobs. And four, decades of discrimination and distrust leading to avoidance of the white-dominated healthcare system. Next slide. Five, rumors that Black people were less susceptible to the virus, or rumors that Black people were more susceptible to the virus due to biological differences between the races. Another point that was raised often was that structural inequalities in health, wealth, housing, and education were the underlying causes for this disproportionate impact. What was not mentioned in these responses was a failure of public health at the city, state, and federal level to address health inequalities that have risen from systemic racism in the US society. The governor of Illinois actually went so far to say, quote, "We can't solve these issues right now. Decades, maybe centuries of inequality of application of healthcare to people of color are part of this problem." And the governor's comment was quite striking to me, given the thousands of articles and books published on health disparities and the 2 decades long effort by the federal government, largely through the efforts and policies of the NIH, to address these inequalities. At a 2000 hearing before the Subcommittee on Public Health of the US Senate entitled Health Disparities Bridging the Gap, Senator Frist opened with the following statement. Next slide, please. "A comprehensive strategy," he said, "describing the directions that we must undertake to bridge the gap in health disparities will require collaboration among policymakers, researchers, political institutions, medical institutions, and affected populations, and affected communities. And we must examine if health disparities are widening or narrowing. We must examine whether health disparities are based on risk factors, behavioral factors, or biological factors. And we must examine what our response to health disparities will be in the future to close the gap." Now, next slide. In this hearing, which was 2 decades ago, the senators heard proposals for the collection of better data, disaggregated by race, ethnicity, and sex, better monitoring, analyses of rates of specific diseases associated with health disparities was recommended as well. Yet, in the last months, there have been renewed calls, certainly from women and minorities, congresspeople, for just this exact same kind of data and monitoring. And we realize now that historians have not even begun to analyze what happened over the last 2 decades and look further back that rendered the nation's most susceptible populations, most vulnerable groups, most susceptible, as I should say, to COVID-19. Next slide. The problem is not a new one. We can go back 80 years. We can go back another 20 years, I should say, to the 1980s. And what we know from that period of time is this. And this is a quote from a very powerful historical study of public health in the American South. And the quote is really worth repeating in full. "The continual health lag that was apparent in one southern state that had long been the region leader in public health programs and commitment in the early 1980s, an accounting of the 10 leading causes of deaths for whites and blacks revealed that, with 2 exceptions, Black men and women perished at rates that were higher, consistently and significantly higher than whites, and that this existed in 1980, this historian wrote, was a grim reminder that too large a proportion of Black families in this state and every other Southern state, quote, live outside of every legal, medical, and social advance our nation has made in this country up until that time. In 1980, these comments should have been a clarion call that there were significant numbers of people, largely poor, largely African American, in many respects concentrated in southern states in the United States, who were not benefited from this progression of efforts that we had made as a nation to improve the quality of life and protect those populations from suffering from epidemic diseases and other health disparities. Next slide, please. So rethinking our healthcare system during and after The current pandemic, of course, requires no less a radical restructuring of society that was required in the 19th century during the era of Reconstruction. The challenges of that era, including pandemic disease, can offer for us some guidance today, even when efforts failed, as we work to address historical inequalities and begin to confront injustice and enduring racism. Next slide. So I'm going to try to give you just a short summary of, and I don't have much more time, of what is a very long history. But it begins, and this material will be made available to people. It begins when, at the end of slavery, at the end of the Civil War. And at the end of the Civil War into the 1870s, we call the period of Reconstruction. And this is a moment when the newly freed slaves had very few resources of their own to support themselves financially, educationally, or to support their health. And what ensued is what the historian Jim Downs has noted. What ensued was the greatest biological catastrophe of the 19th century, as epidemics of smallpox, of cholera, of yellow fever, and other diseases ripped their way through starving and ill-housed people, leaving almost 1 million people dead. This is the 1870s. Okay, and what happened? White observers said, well, this must mean that Black people aren't fit for civilization because they can't protect themselves from these diseases. And it means that, perhaps they should be re-enslaved. Or perhaps they're just simply a weaker race, and in time, they might die out. And so we see the beginning of a problem where there's structural inequalities. That's the end of the 1870s into the early decades of the 20th century. The creation of a class of Black yeoman farmers, which was promised during Reconstruction, had it occurred, might have at least put a dent in the rise of Jim Crow or transformed the poverty of this newly freed group of people. But it did not. And it set in motion a migration of Black people out of the South into crowded cities in the North. And instead, the highly visible health and economic inequalities that were present for Black people in the South moved north and into the West. And the problem worsened. And thus, these inequalities were exacerbated by spatial segregation, poverty, and a healthcare system that all but ignored them. Next slide, please. As a consequence, public health officials, epidemiologists, social scientists, physicians, and the media since the early 1900s have continually rediscovered health inequalities, health gaps, or health disparities, as they are now called, that continue to separate the life chances of whites and people of color. Explanations of this gap still pivot among assertions of inherent genetic differences. In other words, people of color must be biologically different, and that's why they're so susceptible to disease, or it's attributed to underlying conditions and comorbidities, which are just echoes of how observers interpreted the spread of epidemic diseases among the newly freed slaves at the end of the Civil War. Next slide. So we also know that, I'm sorry, could I have the next slide? Okay, what I wanted to say is that racist policies have continually deepen the disparities that have been chronicled over and over again, ensuring the enduring health consequences of poverty, such as overcrowded and substandard housing, the inability to transfer wealth between generations, poor education, insufficient medical care, subprime mortgages, and discriminatory loan practices, redlining of available housing, food deserts, environmental pollution, and jobs that make vulnerability to infectious diseases and stress-related illnesses inevitable. It's racism, it's not racial difference that makes this possible. Next slide. So in conclusion, confronting COVID-19 and addressing racism in our public health system and medical system today requires prioritizing and guaranteeing economic rights, full citizenship for Black Americans and other marginalized groups. Reforming our public health systems have to be part of also the solution to racial injustice. We are now going to be facing, in a few months, prioritizing vaccine availability at low cost or no cost, or whether or not we will set up a system that will require equitable distribution across many communities. We'll have to tailor health education messages. We'll have to work in coalitions on broader issues and make sure the government responds fairly on all these essential first steps. So restructuring our health system and our public health system will not only improve conditions for African Americans who have been disproportionately affected through a long history, or other groups of marginalized communities. This will benefit all Americans because, as I showed you that map, this pandemic is spread across this country. Viruses know no color line. So thank you for your attention, and I look forward to the questions.
Dr. Hammonds, can you hear me?
Yes.
All right, Dr. Hammonds, this is Jason Maderer, and I am in news and media communications at Carnegie Mellon. And for the next 20 minutes or so, we're going to do some Q&A. And I wanted to start with a question, but before I did that, anyone who's watching can totally put in questions in the box at the bottom of your screen, as we are going to take some of those questions and present them to you over the next 15 to 20 minutes. One question I wanted to dive into before we dive into the topic at hand that you laid out so wonderfully in your presentation is, what put you on this path for wanting to study these topics? What was it in your life that propelled you toward this?
Well, that's a really great question, because if you look at my vita, it doesn't quite seem so obvious. It seems obvious to me, but perhaps not to many other people. Well, as you know, my background is in engineering and physics and computer science. And when I was studying those topics in engineering school at Georgia Tech, and certainly and studying physics and computer science at MIT, it didn't take me long to look around and see that I was one of the only few African American women studying those topics. And I wanted to understand, why was this the case? Why were there so few African Americans, Latinas, and other men and women of color from marginalized groups in the United States? Why were they not there studying these topics as well? And I really wanted to understand that question. Also, being a woman, at the time I started doing this work, there were very few women doing engineering and science, certainly at places like Georgia Tech and MIT. And so I really needed to understand, what is the problem of gender and race in American science and engineering? My physics professor, who is still a mentor of mine and a good friend, I would pepper him with questions, and he would always say, these are not physics questions. And finally I said, but they're physics questions for me, because the climate was uncomfortable. There seemed to be hostility toward women and people of color in the department. and other engineering students that I knew who were of color also experiencing these things. We're like, what is the problem here? And so that led me to the history of science, to try to understand the culture of science, the culture of scientific communities, what had been the history of women's participation in science, the history of African Americans' participation in American science. I didn't know anything about any of those things. And I really needed to understand, because I needed to understand why the situation that I faced was so complicated and so difficult. Not that studying physics isn't difficult anyway, but it seemed to have a particular valence because I am an African American woman. And so I turned to the history of science to answer the kind of questions that I needed to answer. But the reason it moved me to the history of disease is this, because when I took my first class on that at Harvard, one of the things I understood about how you study disease historically, you have to understand how ideas about what diseases do in the laboratory, how scientists study them in the laboratory, how public health people apply that laboratory science to the streets, and how clinical medicine use that, the information and the knowledge on individual patients. I found, and you have to do that in complex social situations and political situations. So I found that to be absolutely intriguing, to understand science in a social context through the lens of disease. And that helped me also get back to some of the fundamental questions I wanted to understand.
All right, great. All right, so let's dive back into the topic at hand. So given the many inequalities present, can you point to maybe one or two of the most foundational inequities or inequalities that, if addressed well, would be the best catalyst to make the most long-term difference in all of the areas? I know there's a lot packed in there.
Yeah, there was a lot packed in there. So I think there were probably two things, and well, probably more, but I'll just say two right now to answer your question. I think what COVID has showed us is the ways in which the first mitigation strategies that were put forward was social distancing. Yet, as people were being asked to be socially distanced, but the question wasn't posed, who can do that and who can't? And so actually the poorest people and in communities where there's high density population, right? Those were going to be the most vulnerable to the virus then, if social distance was crucial to keeping the spread low. So if you look at Massachusetts and you look at my town, Boston, and you look around, and I immediately said, it's going to be Chelsea. It's going to be Dorchester, where it's going to flare up first, because those are places where there are triple deckers housing. There are multiple families across generations live in single family apartments, right? There's very few single family homes. To me, if you know that, then you knew that those were going to be hotspots, and they have been hotspots. And so how the notion that, that public health practitioners and leaders could say social distancing without taking account quite publicly of who was going to be able to social distance and who wasn't. Also, a lot of people who lived in those same high density neighborhoods were bus drivers and sanitation workers and people who had restaurant workers with a lot of public facing jobs. So again, they were going to be exposed through those routes as well, and not have many opportunities, excuse me, to be distanced and to not do their jobs. They couldn't work at home. Also because our healthcare is tied to employment. So I think that's the second point that was made very clear early on, that as long as we keep healthcare, the ability to have good healthcare linked to employment, in moments like this, people will suffer. Excuse me.
I will take my time with this question to allow you to get a drink of water, because Dr. Hammonds has a cold actually gutting through this one as we do Q&A. In the meantime, please continue to send in questions at the bottom of your screen. Here's another one. And you talked a little bit about population and urban centers. How significant is the interaction between population density and healthcare outcomes? Do Black Americans in urban centers have significantly worse healthcare outcomes than Black Americans in, say, suburban or rural areas?
Well, that's a complicated question in the sense that it depends on where you are. So in major cities where African American communities are densely populated, you will see high rates you'll see worse health outcomes is what I'm trying to say. But if you go into suburban areas in those cities, also could be African American communities, the rates may not be as high based on that particular factor as well. Health outcomes could be reasonably well. But if you go to rural areas where there are concentrations of African American people, so in the South, rural areas of the South, many African Americans have very, very poor health outcomes because there's no infrastructure there, because their access to healthcare in those kinds of areas is quite limited. And so the outcomes are worse because of the lack of access to care rather than the fact that they live in densely populated areas. And then overall, I would say that we've looked historically and contemporaneously at the fact that there's a great deal of distrust in African American communities across issues of class about how they're treated in the healthcare system, which has engendered a practice which is not good, but I understand the reasons for it, where there's reluctance to seek out medical care when one should. And that's a problem we're going to really have to face as we start talking about the vaccines.
How about reforming public health and the concerns about privatization of healthcare? You mentioned that in your keynote. Can you talk more specifically about what you'd like to see?
Well, I mean, the first thing I would like to see is far less fragmentation. I'd like to see, so it should not make a difference if I live in Massachusetts or I live in Georgia in terms of how the best practices of public health are implemented. But right now, it does. It does make a difference. If I lived in the town 30 miles outside of Atlanta, where both my parents grew up, I grew up in Atlanta, but where the town where both my parents grew up, then immunization rates are low there. There's people have real problems with clean water supplies. I can't even believe I'm saying that in the 21st century. And so there are some structural things that are there that in Massachusetts exist to a far less degree, because the healthcare system and the public healthcare system in Massachusetts is far robust. It's evidence-based. It's based on the best science, and many people like to refer to Boston as the medical mecca. But it is fundamentally different than Newton County, Georgia. But if we have, so that speaks to, do we want a system that you can have radically different outcomes based on the infrastructure of public health? Or do we want a national system of public health so that we can ensure that the best of the basic practices that we think will make people have better lives are relatively evenly, I'm not naive, but are relatively evenly distributed across the country?
Here's a question that we keep getting pinged at, and we're taking your questions. Please go ahead and continue to write in the bottom of the screen. Everyone wants to know, what can we learn from the past and apply it to right now? So, I mean, when you look at the 1918 flu pandemic, for example, there must be things that mirror what we're seeing now.
So one of the things that when I look at the pandemic, something like the 1918 influenza epidemic, again, it was a moment where I know a fair amount. I'll just say in the beginning to explain. There's a fair amount to be said about Chicago as a site. And this is a good one because historians have really studied this one quite a lot. And so there was a moment of segregation. One of the things that happened during that time is that public health officials were not particularly interested in providing good public health to the Black communities in Chicago, in the city. They just wanted to keep them separate. So keeping them separate and doing certain things that they thought would help mitigate the spread of the influenza among white communities and differently and pretty much neglect Black communities. So, but they also closed schools. They increased the number of nurses available to care for people because there really wasn't that much you could do once someone got the flu. You had to take care of them. They refused to allow, as you know, we were about to go to war. We were beginning to have troops going to war. Black women were prevented from serving as nurses in the military to provide care for the soldiers. So racial politics walked right in the middle of this. Okay, an already existing system where there were very few Black hospitals in Chicago at the time. In fact, it had some, which was better than many other cities, which had relatively fewer than even Chicago had. So what you see is the way pre-existing ideas about susceptibility to disease based on ideas about race and the behavior of people of different races and who should be protected and who should just be a contagion that's just like the flu itself kept separate, shape the practices that were being instituted. And again, just like my example about, knowing my understanding of what happened in Chicago informed the fact that I knew that Chelsea, Massachusetts people were going to be more at risk, because that has become part and parcel of the public health practice that should be reformed, to not ignore the most vulnerable population and continue to believe that you can keep people separate. So one of the other things that happened in this, and I'm probably giving too long of an answer, but one of the other things we understand about that point that happened early on, when people started saying African Americans were disproportionately affected by COVID, there were places where people said, where white people said, well, I live in a white neighborhood, so that means I won't get it, because there are no Black people here. So the interpretation, the sort of common sense of it, if you didn't live near the source of contagion, then you were protected by that. That's something that should be aggressively challenged in this day and age by any public health leader, public health department, and should never shape the distribution of any kind of interventions or resources, therapies, etc. So those are the kinds of things we look at.
We have about 5 minutes, so I want to squeeze in a few more. These seem like such big picture, someone else has to do something issues. Let's go a little more personal. What can a neighborhood coalition do to resolve lacking health infrastructure in, say, the rural South or in our neighborhoods? I leave you to choose how you want to address that, but what can, more on a personal level, what can be?
One of the things that I try to talk about when I teach, excuse me, the history of health disparities, is to talk about also the long history of health activism in Black communities. So, one of the things I was heartened by late in the spring when it was, I think the city was Philadelphia, and it was very difficult for people in some of the Black neighborhoods of Philadelphia to get access to testing. So a group of Black physicians bought a van, got some testing equipment, and started going to door to door in those communities. And that used to happen in the 1940s. The Alpha Kappa Alpha sorority, which many African Americans who are listening to this would know, bought a car and packed it up with antibiotics and other kinds of medicines and drove through the South and stopped at little towns that didn't have doctors and looked at kids and took care of kids that way. People have done that. You do here in Boston in the 1960s. Black medical students at Harvard Medical School got a bus and did the same thing and drove through Black neighborhoods and set up mobile clinics to do the same kind of thing. So we have a history of actually being personally on the ground, and people who are setting up in places where there are food deserts, bringing people fresh food, making sure that if kids who were in neighborhoods where they were used to getting their lunches, the only lunch they would possibly have, if and only if they were at school, the people who are now going to schools, picking up those lunches and now redistributing them and going to those kids' homes and giving them those lunches. Those kinds of things show that we don't have to be limited by what official agencies and institutions do. We can get up ourselves and go and do the things that people need. And I am very heartened by such efforts. And now what's going to take as we approach issues relating to vaccines is we're going to have to fight really hard to ensure that people who have less resources will also have equal access to them.
In our final minutes then, and we'll wrap it with this. Let's stick with the positivity. You know, we watched the keynote and it's just a roller coaster of emotions. Continue on the what makes you positive about where we can go or where we are going.
So I think we're at a really important point, and I feel that gives me hope. One, I think that the rapid development of vaccines, which is unprecedented in history, is a good thing and may help the federal government recognize that we can mobilize the best of the scientific institutions to turn their attention to a public problem that needs to be solved and needs to be solved fast. That's one. And number two, I think that the fact, as I said before, pandemics don't produce inequalities, they reveal them. And we can take this moment and say, we've studied health disparities for a very long time. It's now time to fix health disparities. We ought to take this moment of crisis and use it in the most positive sense to deal with these things that we've turned our eyes away from for so long. And we can do that.
You sound positive, and we believe with you. Thank you so much. You know, not just for the 45 minutes, but all the planning leading up to this. Doing a virtual conference is totally different, but we're grateful for your words from Boston. Thank you so much.
Thank you.
All right, that is Dr. Evelynn Hammonds from Harvard. We're going to take about a 15-minute break, and we will reconvene on the channel at 2:05 with our health panel discussion. My name is Jason Maderer, and on behalf of Evelynn, thanks for sending in your questions, and we'll see you at 2:05.
Thank you.